Welcome to the Facebook and YouTube live session about pancreatic cancer awareness. So now we have Dr. Ranjan Mohanty, Senior Consultant Surgical Oncologist, and myself, Dr. Sthiti, Consultant Radiation Oncologist at Apollo Cancer Centers. And today we'll discuss about pancreatic cancer, causes, risk factor and management.
Thank you, Dr. Sthiti. And today I am Dr. Ranjan Mohanty. I am a Senior Consultant Surgical Oncology in Apollo Cancer Center, Bhubaneswar. I will be speaking on the surgical management of pancreatic cancer, its presentation and surgical management of pancreatic cancer. The very beginning I would like to say pancreatic cancer is one of such cancers which nobody wants to have, and the reason being that the symptoms are very vague and the diagnosis is very late, and the treatment is not very effective. Even with the best kind of treatment in the best centers, the 5-year survival is around 5 to 7%. So the basic idea of pancreatic cancer management revolves around a very good resection or surgical protocol that has to be followed by all the centers. Because every year around 2 lakh people die of pancreatic cancer. It's the 4th leading cause of death. Most patients present very late. 50% of patients they present in a metastatic condition, metastatic stage. Half of the patients present with metastatic disease. Only 20% of patients deemed resectable, and the rest 30% they are deemed resectable, but they are locally advanced, and most of the time the margins are positive, or it's not a R0 resection. The 5-year survival, despite all these advancements in treating surgical protocols, your chemotherapy and radiotherapy, it stands around 7.2%. Well, the pancreatic cancer, the possibility of cure limited unless the disease is detected early and completely resected. The disease being detected early, it is very difficult because pancreas is a retroperitoneal structure, and the area around which the structure is there, it's around, there are a lot of structures in and around that area in the epigastrium. The stomach is anterior, the retroperitoneal structures are posterior to that, the liver is just above it, and the pancreatic duct merges with the CBD, so jaundice is very common in these patients. The gallbladder is around, the gallbladder symptoms can merge with pancreatic symptoms. So pancreatic cancer, the diagnosis is very difficult and very late, and it's very difficult to diagnose the cancer in a very early stage. The clinical features are very vague. The patient presents with pain, weight loss, fatigue, anorexia, which can be presented by a lot of cancers or a lot of conditions. Pain, abdomen is there are a lot of, more than 200 causes of pain abdomen, and weight loss can be there without a malignancy also, due to whatever reasons. Fatigue and anorexia are very vague, but one of the common symptoms of presentation in a pancreatic head malignancy especially is a painless jaundice, which is present in 50 to 60% of the patients, which leads to these symptoms, the features of obstructive jaundice leading to steatorrhea and malabsorption. The another symptom which is not very common in other people, section, is a recent onset diabetes. Diabetes normally occurs in people who are genetically, they have either type 1 diabetes or type 2 diabetes around 30 years of age. But recent onset of diabetes at around 50 years of age is a suspicious finding. The patient may present with a metastatic disease because the patient has not been diagnosed in early stage. He might present with ascites, palpable mass, supraclavicular node, and severe jaundice. So what we have in mind is, once we think of pancreatic cancer, we have to know a few things. We are not concerned about the TNM staging. What we are concerned about is the curativeness of your treatment. Whatever treatment you are going to do with the patient, whether it will be curative or not. So first thing is whether the disease is resectable or not. Second thing, if it is not resectable, is it borderline resectable? By doing a vascular resection or vascular anastomosis, can you still give a R0 resection or not? Third is a locally advanced or non-resectable disease, where the treatment is only palliative. And fourthly, metastatic, even the palliative procedure may not be effective. So you can see in this resectable lesion, you can see the SMB here. Whether the disease is resectable or borderline resectable depends upon the vascular encroachment of the tumor. Whether the tumor can be separated from the vessels or not, or whether the tumor can be resected along the vessels with reconstruction of the vessels or not. So the resectable or borderline resectable depends upon a lot of factors like the capabilities of the center, capabilities of the surgeon, and availability of all the technical aspects of a vascular resection and reconstruction is also important in these cases. So resectable or borderline resectable, I will come to the points later on. So in first slide I have shown here, it's a clearly resectable lesion. It is away from the SMB and the SMA, and the onset process is clearly defined here, and I think the resection can be carried out. And this is a borderline resectable tumor where the lesion is aborting the superior mesenteric vein, but it is around 180 degrees. You can put a scale here and find out it's almost less than 180 degree abortment. And still in these patients, either resection or the tumor can be removed with a reconstruction of the SMB, and the SMA is free here. So it's a borderline resectable tumor. Unresectable tumor, it's more than 180, around 360 degree, whole of the tumor engulfing the SMB. Here the SMA is going out, which has been narrowed, and probably vascular reconstructions are very difficult in this patient, and probably this is a unresectable tumor. The non-resectable and borderline resectable, which I said I will be speaking on that. Encasement more than 180 degree invasion are non-resectable of the SMA of the celiac artery or the common hepatic artery. All these areas, if the invasion is more than 180 degree invasion, where a resection may not be possible. So these are non-resectable tumors. Occlusion of the SMB and total vein confluence, especially. SMB alone can be resected, but at the confluence, if it is involving, then probably reconstruction may not be possible. Borderline resectable lesions about visceral arteries. About the visceral artery, first slide I showed, is less than 180 degree invasion. Distortion of the visceral veins or even occlude the SMB PV confluence, but venous reconstruction still technically feasible, but arterial reconstruction would be difficult. So non-resectable and borderline resectable tumors, they revolve around the invasion of the vessels, whether they can be removed or not, they can be resected, and reconstruction can be done or not. So pancreatic cancer, once a patient comes to us, so I want to know whether it's a metastatic disease or not. If it is non-metastatic, I want to know whether it is a resectable disease or not. So there are a lot of studies showing the superiority of different modalities of investigations, but the gold standard is the CT scan. Proper multi-slice, especially more than 32 slice or 64 slice CT scan would be better, so that you have thinner sections telling you exactly where the tumor is, how far the tumor is from the vessels, and whether there is 180 degree encroachment or more than that. MRI is not as superior as good as CT. Maybe certain centers follow MRI protocols also, but with the advent of better CT machines and less cost than an MRI, then CT has become the gold standard. But MRI has its place, like you have people who cannot be given contrast of CT scan, and their MRI is better in these cases. Endoscopic ultrasound, I would say endoscopic ultrasound, little bit superiority is there where the tumor is very less. 2 centimeter lesion where CT might not pick up, or it picks up but it's not very clear in the lesion. CT doesn't mostly pick up lesions less than 1 centimeter. So smaller lesions, and endoscopic ultrasound is also better if you want to have a biopsy or a FNSC before giving neoadjuvant chemotherapy, which may not be possible in a CT guided biopsy or MRI guided biopsy. There it is better. And in smaller lesions also, whether there is encroachment, infiltration of the vessels or not, there this might have an advantage also. But it doesn't give any information farther away from the stomach or the lesion. ERCP is becoming slowly obsolete, because the real concept of decompressing the liver in a jaundice patient is going away with the advent of better antibiotics and better surgical procedures. ERCP is no more being practiced in a lot of centers, but yes, if the jaundice is very high, maybe more than 15 or so, and you think that the patient won't be is a poor candidate for surgery, there a palliative stenting or a decompression stenting can be done, or even a PTBT or a percutaneous transhepatic decompression might be done. PET CT, yes, PET scan has a role in finding out lesions somewhere else, which can detect a metastatic disease. Diagnostic lab, yes, 100%. Any case of pancreatic malignancy or a gastric malignancy should, whether he is undergoing a neoadjuvant chemotherapy or upfront surgery, in these patients diagnostic lab has to be done to know that the liver is normal, it looks normal, because less than 1 centimeter lesions in the liver might not be picked up by the CT scan itself. So CT protocols that have to be followed for pancreas are: non-contrast phase, you have to see the evaluation of the pancreatic calcification. Arterial phase, you have to know the early arterial phase, evaluate the pancreatic vasculature without interference from venous, because vein has the blood, the contrast has not reached the vein. Here you can know the vasculature. Late arterial phase is to distinguish pancreatic tumors from adjacent normal pancreatic tissue. Evaluates hypervascular liver mets also in patients with neuroendocrine tumors of the pancreas. Portal venous phase, evaluation of the relationship with the veins and the hypervascular liver metastasis in patients with adenocarcinoma. Pancreatic cancer staging, I have said CT, MRI, UVS, ERCP, PET CT and diagnostic lab. One or multiple modalities may be used for staging the disease. In US, I have already told you, small lesions, vascular involvement very closely it can monitor, and a FNSC or a histological diagnosis if you want, it is better in those conditions. Role of staging laparoscopy, approximately 50% of patients with pancreatic cancer can have liver or peritoneal mets on operation. Staging laparoscopy can avoid unnecessary exploration. You think the patient is operable, you put in the scope and find that there are liver mets which are less than 1 centimeter, which has not been picked up by the CT scan. Prospective study at the MSKCC of 115 patients, 36% of the patients saved from exploration or a major procedure. Most common site pancreatic cancer, we have known, we have staged, we should look at what we are going to do during the surgery. Most common site is the pancreatic head, 78%, and there are duct carcinomas and adenocarcinomas. In these patients, a Whipple's procedure involving the removal of the C of the duodenum and the lower part of the combined duct, the pancreatic head and the duct is removed and bypassed. Body and tail, here it's a distal resection of the distal pancreatectomy, which is in 20 to 25% of the cases, it can cure the disease. This is a curative lesion. Surgery is the cornerstone of treatment. I think a R0 resection, complete removal of the tumor is the only cure, and in these patients, only adjuvant can palliate, and surgery is the cornerstone. In the late 1960s, postoperative morbidity rate was 60% and mortality rate approaching 25%. Nowadays, after several decades, mortality rate is less than 2% and morbidity rate is 30 to 40% in high volume centers. Surgery for pancreatic cancer, what is our aim? A microscopic R0 resection, margin negative R0 resection. There should be no microscopic disease left behind if you are planning for a surgery. Evolution of the procedure from Walter Koss in 1914 to Allen Whipple in 35. He did a Whipple procedure in 2 stages. He resected the CBD, he resected the duodenum and the jejunum, but in second stage he anastomosed everything, and a second stage he removed the tumor. He did a bypass first, then removed the tumor in second stage. But in 41, one stage pancreatic duodenectomy was described by Whipples, and that is being followed nowadays. So it involved the resections can be, if it is a head, then pancreatic duodenectomy, distal pancreatectomy for distal tumors. Segmental pancreatectomy is not done for malignancies because of, if you leave the middle portion of the pancreas, lymphatic dissection may not be complete, and we are not happy about the lymphatic clearance. So either it's a extended Whipples or a distal pancreatectomy. We make the pancreas half, the proximal part is Whipples and distal is distal pancreatectomy. Segmental pancreatectomy we don't do in malignancy. So, and if whole of the pancreas is involved, total pancreatectomy is another procedure. So anatomy of the pancreas is supposed to be, we have to be very knowledgeable about where the vessels come from and what are the likely areas where you should not resect before confirming that the disease is resectable. Like at the onset process, just over the artery, the supramesenteric artery, if you have gone and resected there and it is invading the supramesenteric artery more than 180 degrees, you have reached a stage where of no return. So at that stage, you are in a soup, you don't know what to do. I will not be going into the details of the anatomy. Celiac trunk, yes, everybody must be conversant. The celiac trunk comes out like this. It gives the left gastric here in the lesser curve, and it gives the splenic, which goes to the splenic artery. In a distal pancreatectomy, you have to do a splenic resection also and clear the splenic nodes also. The common hepatic artery goes like this, comes up and gives the gastroduodenal artery and right gastric artery, and the supraduodenal artery, proper hepatic, gives right and left arteries. Arterial supply comes from the anterior and posterior superior pancreatico-duodenal artery, which is the branch of the gastroduodenal, and the inferior branch comes from the inferior mesenteric vessel. And most of the blood comes from the splenic artery. They are the pancreatic branches of the splenic artery. Veins drain into the superior mesenteric vein and the inferior mesenteric vein and the splenic vein. And anatomy must be known to all the surgeons. The onset process goes behind the vessels here, and the operability has to be palpated and confirmed before resection of the pancreas over here. So once the resection, we have to have in mind that duodenum or the stomach is resected up, the CVD is resected up, and pancreas head is resected, and somewhere near the ligamentaries the resection is completed. Preoperative preparation, nutrition is very important. Assess vascular involvement, liver mets, CVD stent placement if necessary. Very rarely this is being practiced because CVD stent placement gives to a lot of fibrosis and lot of post-op complications also. So we are not advocating a CVD stent placement. An absolute indication for biliary drainage is bilirubin more than 15 mg/% cholangitis, because if the patient is having cholangitis, you can't go for a supramajor procedure, and malnutrition has to be taken care of. So the steps of pancreatectomy are very simple, but everybody should remember that you should not resect anything before you confirm that the patient is resectable, the disease is resectable. First step is a Copper's maneuver, mobilization of the transverse colon by opening the gastrocolic ligament and going in. Then you extended Copper maneuver, you give an incision lateral to the duodenum, lift the duodenum medially and just above the inferior vena cava and the supramesenteric vein. You turn it around, just put a finger below the pancreas and look for any signs of inoperability. So once you have extended the Copper's maneuver and lifted the duodenum, you must reach until the left renal vein. Here is the left renal vein. You must reach until that to find out, to know whether the disease you can do a complete resection or not. Third stage is a cholecystectomy, CVD resection and ligation of the GDA. Cholecystectomy is performed here, giving an adequate margin to the CVD and sending the CVD for a frozen margin analysis operatively is very important. The next step is the division of the stomach, duodenum, division of the proximal jejunum. Once you have resected the CVD, now stomach or the duodenum, part of the duodenum, depending upon whether you are doing a pylorus preservation resection or not, and the jejunum is cut somewhere, freeing it from the ligament of trace. Next step is a division of the pancreatic neck over the SMB-PV confluence. Last step is the division of the pancreatic neck over the SMB-PV confluence. Here you must be very sure that the disease is resectable. Once you reach the artery, there is point of no return. Dissection, this sixth step, dissection of the pancreatic head and onset process from the SMB and the artery. And once this stage has been done, completed, the tumor comes out, and now is the stage for reconstruction. Once the tumor goes out, what you are left behind with is a cut end of the CVD, cut end of the stomach or the duodenum, depending upon which procedure you have done, and cut end of the pancreas. So this triple anastomosis has to be completed with a end-to-end or end-to-side pancreaticojejunostomy and docojejunostomy here, and completing with a gastrojejunostomy. We add a procedure routinely ourselves. We do a jejunostomy also here, so that the pancreatic and the bile drains here only, doesn't go into the stomach. This is the specimen after the resection has been done, and the learning points here are duodenum will always be excised due to common blood supply with the HOP, and head of pancreas. Spleen with distal pancreas, because if you are doing a distal pancreatectomy, spleen has to be removed. The gastroduodenal artery acts as a communicating vessel between the celiac artery and the SMA. Positive resection margin SMA is very common. Here you have to be very careful over the superior mesenteric artery, and if here it is positive, then you have done nothing for the patient. The patient will have same result as if he was never resected. Well, there is a few words about the palliative surgery. Laparotomic palliation is not in the best interest of the patient. Some people say because the patient has pain, he has jaundice, let us do a palliative resection. Palliative resection of the disease has no role. The mortality is 2.2 to 5%, morbidity is 20 to 30%, and hospital stay is more than 10%. Operating mortality and regionalization, yes, the operating mortality exceeded 20% until the 1980s. Since then, improvement in morbidity, mortality and hospital stay has been there, and it is improving day by day. Now, still, the result 5-year survival is around 7.2%. The summary, pancreatic cancer remains a lethal disease even after curative surgery. Despite this, surgical resection remains the only option for long-term cure. The morbidity and mortality of surgery have reduced over the 2 decades. In middle, the mortality was so high that they abandoned doing a surgery in pancreatic cancer. But with the advent of a lot of modification in the procedures, and surgery is being done, and if you have a R0 resection microscopically, your results are supposed to be good. Advancement in diagnostic imaging and laparoscopy have contributed to refining the groove that would be benefited by surgery to avoid unnecessary resections. Even resection of, if you are resecting SMB or a portal vein, still you can give the same results, better results rather, can be performed safely, and if margin negative, has the same pattern of recurrence and survival equivalent to that of a standard R0 pancreatic. So it should be done if only SMB encasement is the only, or the portal vein encasement is the only contraindication. That if you can resect, then it gives a good result. Controversies regarding neoadjuvant chemotherapy exist, awaiting results from the multicenter trials. Although controversial, adjuvant CRT is the standard of care. Thank you. I think we'll proceed with the next speaker, Dr. Sthiti. She is a consultant radiation oncologist in Apollo Cancer Center in Bhubaneswar. She will speak for topic.
Thank you, Dr. Ranjan. We'll now continue with the next topic, changing paradigms in the treatment of pancreatic cancer. So as we have already discussed the anatomies, Dr. Ranjan has very nicely elucidated what is the anatomical location. Like, it is an elongated, coarsely lobulated gland which lies transversely and retroperitoneally in the posterior abdomen, approximately in the L1, L2 level. Because of its retroperitoneal location, probably the signs and symptoms appear late, and that is the reason most of the patients in our subcontinent, they present late. So this is the basic anatomy. Like, it's divided into 4 main parts, like the head of the pancreas, neck, body and tail. Coming to the epidemiology, we have already discussed that it is the 5th leading cause of cancer mortality among men and women of all ages. It is a slightly male predilection. It is in the ratio 1.3:1, and diagnosis is usually rare before the age of 45 years, but it rises sharply thereafter. The factors or the causative factors which are associated with an increased risk are advancing age, race like African American, Native female Hawaiians, Jewish. They have slightly more predisposition for getting pancreatic cancer. Other causes are cigarette smoking, genetic syndromes, diabetes mellitus, chronic pancreatitis, cirrhosis, obesity, increased height, low level of physical activity, high fat and cholesterol diet, and also occupational exposure to carcinogens, most commonly benzidine. The genetic abnormalities most commonly we see in pancreatic cancer are the presence of KRAS, P53, KRAS in more than 90% of cases, P53 gene, P16 which is also present in 95% of the cases, MKK4, DPC4 and BRCA2 gene. The most common genetic syndromes and gene alterations we usually see which is associated with familial pancreatic cancer are hereditary pancreatitis, hereditary non-polyposis colorectal cancer, hereditary breast and ovarian cancer associated with BRCA2 gene, familial atypical multiple mole melanoma syndrome associated with alteration in P16 gene, post-Jaeger syndrome and ataxia telangiectasia. So coming to the symptoms, general symptoms which is most commonly we encounter is the classic triad of symptoms, that is pain, jaundice and weight loss. Epigastric or abdominal pain is seen in 90% of the cases, associated with anorexia, nausea, vomiting. Weight loss secondary to malnutrition, and almost 20% present with new onset diabetes. Fatigue and other less common symptoms are migratory thrombophlebitis, which is the Trousseau sign, and palpable gallbladder, which is the Covoiser's sign. If you see the symptoms which are mostly associated with the tumors of the body and tail of the pancreas, usually the symptoms are delayed until invasion of the adjacent organs. Persistent and dull pain in abdomen or upper back. It gets worse in supine position. Invasion or occlusion of the splenic vein can cause thrombosis, splenomegaly and gastric varices. Jaundice is uncommon at early stage. For head of pancreas, the most common symptoms are like 90% have jaundice. It is painless, pain and infection secondary to obstruction of the bile duct. There may be swelling of the pancreas, reduction in the pancreatic fluid excretion and digestive dysfunction as well, associated with malnutrition, diabetes mellitus and weight loss. We have already discussed the workup and staging of pancreatic cancer. The most important test which we usually do is a CBC and a biochemistry, followed by endoscopic ultrasound, CT, abdomen and PET CT. Biopsy, a pathological diagnosis of biopsy is not required before surgery, but it is necessary before administration of neoadjuvant therapy and for patients staged with locally advanced or unresectable and metastatic disease. We can also do a fine needle aspiration with the help of endoscopic ultrasound guidance or a brush cytology with ERCP. Now we come to the staging part. It is usually done with tumor, with the size of the tumor, that is T and nodal and M for metastasis. Coming to the management, surgical resection is the only potential curative technique for managing pancreatic cancer. More than 80% of patients present with disease that cannot be cured with surgical resection. So coming to the management of pancreatic cancer by radiation. These are the three important questions we need to answer. Why? Is there a role for local therapy with radiation in a disease with such high rate of distant metastasis? When do we see the application of radiation therapy? It may be during resectable disease. Is there a role for adjuvant post-op radiation? Borderline resectable disease. Does neoadjuvant RT improve the rate of R0 resections? And third is locally advanced unresectable disease, where is there a benefit over chemotherapy alone? And how we can see, we will learn in the later slides, the technological advances, that is stereotactic body radiation therapy, actually helps us in improving the outcomes through dose escalation. Coming to the first question, like resectable pancreatic cancer, is there a role for postoperative radiation? We all know that 50% of the patients have resectable disease at the diagnosis. Rest of the diseases are rest of the cases are there in locally advanced stages. Post-op chemotherapy is the standard of care. But is there a role of post-op radiation? We can see in GITSG trial 9173, where 42 patients were randomized to observation or concurrent radiotherapy after R0 resection. The survival benefit with concurrent radiotherapy we can see compared to surgery alone The median survival was 20 versus 11 months and 5-year overall survival was 19 versus 5. But treatment fields, prescription and chemotherapy are now outdated. So coming to the next slide, or the next trial was SPAC1 trial, which was the only randomized trial comparing adjuvant chemotherapy to concurrent chemoradiation therapy. If we see the survival, it was worse with concurrent chemoradiotherapy versus no concurrent chemoradiotherapy. 5-year overall survival was 10% versus 20% and median survival 15.9 months versus 17.9 months. Survival was improved with chemo versus no chemo. 5-year survival 21% versus 8% and median survival 20.1 versus 15.5 months. So, is concurrent chemoradiotherapy really detrimental? Coming to the next analysis, where analysis of over 6,000 patients with resected pancreatic adenocarcinoma were identified in the NCDP analysis, where 38% received adjuvant chemo and 62% received adjuvant chemoradiotherapy. The chemoradiotherapy arm was associated with improved survival. In the RTOG 0848 trial, the randomization was done. In arm 1, gemcitabine alone or a combination chemotherapy was given for 5 months, and in arm 2, gemcitabine plus erlotinib into 5 cycles. Then it was randomized to arm 3 or arm 4, where another 1 month of gemcitabine or combination chemotherapy were added. In arm 4, 1 month of gemcitabine or combination chemotherapy followed by radiation with either capecitabine or 5-FU were added. So 45% of patients developed local recurrence after resection. So sites of recurrences were mapped and 90% of these recurrences were local in close proximity to the celiac and the SMA. Standard fields encompass the tumor bed and regional nodes, but the area at risk for recurrence is likely smaller. So reduced target volume in these cases will actually help us in minimize the toxicity and could improve efficacy by allowing for a dose escalation. So the conclusions for resectable disease were adjuvant chemotherapy improves overall survival and is the standard of care. RTOG 0848 is evaluating the role of concurrent chemoradiotherapy in the context of modern chemotherapy and radiation. Will there be a benefit as systemic therapies improve? Smaller treatment volume may reduce toxicities and allow for dose escalation, which may lead to improved local control. Coming to the next question, should we consider new adjuvant therapy? Current studies are evaluating whether chemo or radiation in the neoadjuvant setting can improve control of micrometastatic disease and R0 resection rates. Coming to borderline resectable disease, potential for resection with positive margins is increased due to the proximity of the tumor to vasculature. Contact with the common hepatic artery, less than 180 degrees contact with SMA, more than 180 degrees contact with SMA or PV, or contour irregularity or thrombosis of the vein. Survival after an R1 or R2 resection is comparable to survival in patients with unresectable disease. So does neoadjuvant therapy improve outcomes? Does it help us to downstage the tumor to improve the R0 resection rate? And does it address the micrometastatic disease? Coming to the MDAC experience, we can see 160 patients with borderline resectability. 78% of patients received pre-op gemcitabine based chemotherapy and concurrent chemoradiotherapy. 41% of patients underwent resection after neoadjuvant therapy. You can see there was a 94% rate of R0 resections with median survival 40 months with resection versus 30 months without resection. Coming to locally advanced unresectable disease, 30 to 40% of patients have locally advanced unresectable disease at diagnosis. Studies to date evaluating the addition of concurrent chemoradiotherapy to chemo have conflicting results. In the ECOG E4201 trial, the concurrent chemoradiotherapy arm versus gemcitabine, there was an overall survival benefit with concurrent radiotherapy that was 9.2 in comparison to 11 months. Induction chemo followed by concurrent chemoradiotherapy versus only chemotherapy, there was a median survival improvement of 15 months as compared to 11.7 months. So here we can see in the LAB07 trial, induction chemotherapy followed by gemcitabine or gemcitabine plus erlotinib. If there is no disease progression, we can follow again with one cycle of gemcitabine erlotinib followed by chemoradiation 54 gray plus capecitabine or plus minus erlotinib. So the overall survival benefit to concurrent radiotherapy arm after 4 months of induction gemcitabine was around 16.5 months, and with concurrent radiotherapy it was 15.2 months. But we can see significant local control benefit with concurrent radiotherapy arm, where it was increased to 46%, and there was a prolonged treatment free interval after concurrent radiotherapy to 6.1 versus 3.7 months in only chemotherapy arm. So concurrent chemoradiotherapy is still commonly employed in these patients without progression after maximal response or tolerance of upfront chemotherapy for several reasons. CRT results in a local control benefit, and local progression can cause significant morbidity. The prolonged treatment-free interval is beneficial for patients with limited lifespan, and significant advances in systemic therapy have improved outcomes for these cases and likely impact the role of radiation. Coming to locally advanced unresectable, where concurrent radiotherapy was given with modern systemic therapy like FOLFIRI and oxaliplatin and gemcitabine nab-paclitaxel compared to gemcitabine alone. These regimens are increasingly being used to treat locally advanced disease. The meta-analysis showed that the median survival for FOLFIRI plus oxaliplatin arm was 24.2 months, and the Yale phase 2 study also shows a median overall survival of 26.6 months. With improved control of micrometastatic disease in these studies and distant progression, the addition of radiation is more likely to be of benefit. So coming to radiation dose escalation, the technological advances like the IMRT and SBRT actually helps us to increase the dose or escalate the dose to the tumors and reduce the dose to the nearby structures. In intensity modulated radiation therapy, the radiation is delivered with multiple beams or arcs. Beam intensity is varied along the whole field. As we can see, radiation dose better conforms to the tumor target, and it reduces all the grade 2 GI toxicities as compared to 3D CRT. By limiting dose to the normal structures like the liver and the spleen, we can allow a safe escalation of dose to the pancreas. Stereotactic body radiation therapy allows us to give an ablative dose of radiotherapy in 5 or fewer fractions, and it focally targets a tumor volume with minimal margins, that is up to 2 to 3 millimeters, with a sharp dose follow gradients to avoid normal tissues. And respiratory motion management also with 4D planning CT and respiratory gating as well as abdominal compression allows us to reduce the margins of treatment volume and motion of tumor with respiration. Image guidance with the use of fiducial markers and CBCT obtained on the treatment machine prior to each fraction, which is merged with the planning CT, and then the radiation is delivered. So it actually allows us a dose escalation where a dose up to 6.6 gray per fraction can be given up to 5 fractions. Here we can see in the JHO trial where 49 patients with unresectable pancreatic cancer, they received gemcitabine for 3 cycles, then an SBRT of 33 gray was given in 5 fractions. The median survival was around 13.9 months, local control at 1 year was 78%, and low rates of grade 2 toxicities were observed. We can see the pre-SBRT area, the size of the tumor is around 6.7 cm, which has been reduced to up to 1.3 cm at about 30 months. So the advantages of SBRT are studies have not compared the SBRT to conventional fractionated CRT. The potential advantages being it allows for larger fraction sizes and thus an improved local response. Local control of 80% at 1 year compares favorably to historical controls including LAP-07 trial. Shorter treatment time, less time off from multiple agent chemotherapy, less delay to surgery, and it is better tolerated. There may be a slight immunomodulatory effect with SBRT. Over 50 clinical trials are currently evaluating SBRT in the management of pancreatic cancer. There is a phase 3 study ongoing for FOLFIRI with oxaliplatin plus minus SBRT for In concluding the session, the first point we know is in resectable disease, adjuvant chemo is the standard of care, but RTOG 0848 is evaluating the role of chemoradiation. In borderline resectable disease, neoadjuvant radiation as well as stereotactic body radiation therapy may help us improve resectability. In locally advanced disease, RT provides local control if disease does not progress after initial chemotherapy, and outcomes may improve with dose escalation techniques like SPRT. There may also be a new role for radiation in combination with immune therapy. So the summary of the treatment: resection is the only chance for a cure, and resectable patients should undergo surgery without delay followed by adjuvant therapy. Borderline resectable patients may benefit from neoadjuvant therapy and then surgery. Unresectable patients definitely benefit from chemotherapy and chemoradiation. Metastatic disease may benefit from chemotherapy or other palliative treatments. Thank you.
Well, I hope this was a good session for the basic learning about pancreatic cancer. Thank you everybody for a patient hearing.